Welcome to the Orthodontics in Conference podcast, where Farouk brings you the summary of key lectures from orthodontic conferences around the world, with your host, Farouk Ahmed.
Hello all, and welcome to day 2 of the Saudi Orthodontic Clear Aligner meeting. I'm excited to be bringing this to you today. We're going to be looking at 5 lectures and covering a range of topics, from looking at basic research and clinical application of aligners to looking at some really solid clinical pearls that we can take away and use in our everyday clinical practice. We'll be looking at auxiliaries and the use of temporary anchorage devices specifically, and how we can incorporate it into our aligners. We'll be ending with looking at Beom Kim's lecture, looking at research and evidence-based about what aligners can predictably achieve and what the limitations are. It's a great day of lectures. Hope you guys enjoyed and look forward to the next episode. Hello all, this lecture is entitled Aligner Orthodontics, From Basic Research to Clinical Application by Tommaso Castroflorio. In this lecture, Tommaso looked at what actually transpires with forces when we apply aligner mechanics. Specifically, he looked at distalization, he looked at cutouts versus buttons, anterior open bites and rotations. So Tommaso started off describing the advantages of using aligners for periodontal patients, how their health outcomes are better with respect to gingival index, bleeding on probing, that was shown by Rossini in 2015. The real advantages are that we can control the rate of orthodontic tooth movement for these periodontal patients by reducing down the linear movements to 0.12 millimeters and angular measurements to 1 degree, essentially half the typical velocity, and therefore control the biological response in a more organized fashion. He gave the advantages of using aligners and mentioned how they are effective for anterior alignment and also comparable to fixed appliances in the buccolingual changes. But these come with disadvantages, and they are not predictable when it comes to excessive movements in the horizontal plane, and most cases require additional refinement. He then spoke about the biological limitations and described actually the limitations that we have are the same as they are for fixed appliances, with rank L on osteoprotegarin being in the same quantity as they are for fixed appliances. Next, Tommaso spoke about distalization. So the typical sequence being sequential distalization, where we move the posterior tooth halfway into the space and the next tooth moves and so on, and using class 2 elastics. And what he looked at was finite model analysis to see, well, what actually happens when we do these movements. What he showed was quite interesting, that when we distalize the posterior tooth, for example the 7, there's proclination that takes place to the incisors. And he explained this in a really easy fashion, is that the aligner, essentially it behaves like compressed coil or open coil between the 5 and 6. We get distal force to the 7, and we also get a mesial vector force which expresses itself with the anterior teeth proclining. Then when we distalize the 6, the same process takes place, distalizing of the 6, but also proclination for the incisors. Now the key bit to this exercise was to look at what happens with the distalization of the 5. Tommaso said this is the greatest likelihood of losing anchorage in a distalization case. Again, it's compressed coil or push coil between the 5 and 6 space. But also this time we've got an elastomeric chain type force happening from the 7 through to the 5. This results in mesial tip taking place to the 6 and 7 tooth, and therefore we're getting anchorage loss taking place. Tommaso explained why this happens. Essentially, the aligner squeezes teeth, it doesn't slide teeth, so we get these two movements happening. And he gave a key clinical tip how to prevent this process. He advised adding in distal crown tip to the molars when the 5 was being distalized, and he advised 5 to 10 degrees. Next, Tommaso looked at cutouts versus buttons for class 2 elastics whilst distalizing. This was really interesting. He used finite model analysis again to look at what forces actually take place through these two different force deliveries. With a cutout, he found that the deformation of the aligner was such that it resulted in intrusion and distalization, our ideal movements. Interesting, when a button cutout was used and the class 2 elastics were done, it actually resulted in proclination and mesial movement taking place to the upper incisors. So he said cutouts are preferred to buttons with class 2 elastics for distalizing. He recommended the use of 3/16 and 6 ounces of force. He gave his protocol for biomechanics for class 2 distalization that involved extraction of the third permanent molars to distalize 50% into the space in a sequential fashion, and to counter that moment of loss of anchorage, he recommended the use of class 2 elastics from the upper fours or the upper first bicuspids until the end of this upper bicuspid has distalized into the space. Then the cutout to move to the canine tooth, and then class 2 elastics to be used from this tooth. He recommended an aesthetic start as part of his protocol, so some anterior alignment for the benefit of the patient, and 1 week turnaround. Next, he looked at anterior open bite cases and described how we have relative extrusion taking place coupled with retroclination, and the main movement really is that retroclination. He described differences in attachment design and showed actually none of them really made a difference to the anterior retroclination, and any attachment seems to do the job regardless of shape. He recommended posterior attachments to reinforce anterior anchorage, and also described from a finite model analysis there's ideal periodontal stresses when we carry out these movements of retroclination and relative extrusion for around 76 grams in the periodontium. He also looked at the clinical study carried out by Harris in 2020, which is quite a large study, looked at anterior open bite correction, and it showed mostly the anterior open bite correction happens through retroclination, but also some anterior extrusion and posterior intrusion. Next, he went on to round teeth, and it's always a struggle to correct with aligners. He mentioned the accuracy is around 40%, so some of the lowest applications of tooth movement with aligners. And that's Simon 2014. So from a mathematical design, what he looked at was different attachment design. What he found was that rectangular and vertical attachments seemed to offer the greatest predictability to movement. But what was interesting when they found this out, they also compared 1.2 degrees of activation versus 3 degrees of activation, and found it's far more predictable to have 1.2 degrees of activation. Now that is different to what we see with Invisalign, for example, where each aligner tends to have 2 degrees of rotational correction for premolars and canines. This lecture is entitled Aligner Orthodontics in Growing Patients, a research-based approach by Tommaso Castroflorio. Tommaso started off by describing the ideal time for expansion to take place prior to lateral incisor eruption, and he quoted Bjorn Zachrisson and Marco Rosa for this. He described the cause of maxillary constriction, and it relates to a change within the population. There was a study carried out by De Ferrier in 2006, and it showed a higher prevalence of reduced intermolar distance between the 1950s patient and also the 1990s patient. It seems to be generational. Describe what is the ideal time for expansion, and how when we look at the growth of patients, the transverse changes of the maxilla tend to take place between the ages of 7 to 11. That's by Nanda 2012. What's interesting is that there's not much force required to separate the palatal suture at this age, and that's the age of 7 to 9, and Hugo de Klerk and Profit wrote about this in 2015. So Invisalign has a product labelled Invisalign First, which allows attachments to take place on primary and secondary teeth, and they are optimized attachments. He described the key to expansion with Invisalign First is the staging approach, which allows expansion of the first permanent molars to begin with, then followed by expansion of the remaining primary teeth. He described this as a neat way to work on anchorage changes. He went on to describe his research looking at Invisalign First on 43 retrospective cases. The average treatment length was 9.7 months, and he described the amount of volume changes were significant, approximately 40% of expansion. He described other advancement options with Invisalign. The mandibular advancement allows active or optimized wings similar to a twin block to be used. They're placed laterally, and this interlocking of the blocks postures the mandible forwards. One of the biggest questions of using functional appliances is the timing for use. Cervical vertebral maturation has been described in the literature by McNamara and Bacchetti, but it's been questioned as to its validity. What he described was how there is a new measure. The development of the second permanent mandibular molar has been shown to have high specificity and sensitivity for peak pubertal growth. And that was a study by Iontate in 2020. So, Tommaso's recommendation for the timing of mandibular advancement is to look at the A and B of 5 degrees, class 2 molars, a convex profile, and also a low angle case, but also now to include second molar development. So, for example, for females, their peak height velocity growth takes place when the root is between a third developed. For males, their peak height velocity is later on in the development, where the root is 2/3 formed or greater. He described how unpublished research, which was coming out in January 2021, shows that when we look at the mandibular advancement appliance from Invisalign versus controls, we get similar amount of growth taking place to the mandible of approximately 8 millimeters from condylium to gnathian. This lecture is entitled Overcoming Aligner Limitations by Using Palatal Mini Implants by Benedict Wilmes. This was a really interesting lecture where Benedict took us on a journey of aligners and TADs. He spoke about the challenges with aligners and how they can be resolved using TADs, his system, his insertion, his technique, but also then applying the mechanics to the process of distalization, mesialization, expansion and protraction. So to start off with, Benedict described how bodily movements are a challenge for aligners. Distalizing more than 2 millimeters is unpredictable, and expansion mainly takes place through tipping movements by Hole 2017 and Zhou 2020. And he said that TADs make a very adjunctive interaction between aligners to conquer these challenges. So, what does Benedict Wilmes use? Well, he uses the Benefit mini screw system from Germany. Usually it's going to be 2 9mm TADs or 2 7mm TADs. His location for insertion is the anterior palate and describes success rates of over 97% by Hofer 2017. He uses the Benny slider, which he was the inventor of, and it shows that success rates of over 4,000 cases of 97%. So a very reliable tool to have. Now the anterior palate is preferred because there's low risk of damage to adjacent structures, high success rate as described, but there is a downside, and he was quite honest about it. It requires some form of wire or attachment to then apply the mechanics to the dentition. So where does Benedict Wilmes place these TADs in the palate? He aims for the so-called T-zone, which is behind the third palatal rugae and also is paramedian. He spoke about the areas to avoid, and that is really the posterior lateral areas of the palate and also anterior to that third palatal rugae. Described the bone can be thin and also the structures such as the incisor papilla in the way. He also mentioned how he's developed in his own clinical practice from initially putting TADs in the midline itself to going paramedian. And he mentioned that the study carried out by Nian Kempfer in 2013 showed that there's better stability for the TAD over the initial 6 weeks when it's paramedian as opposed to being in the mid-palatal suture. So how do TADs then interact with aligners? Well, he described his 2-stage protocol and also his 1-stage protocol. So for 2 stages, it essentially involves using the TADs with a Benny slider, achieve the correction of the malocclusion, the complex aspects, the bodily movements, then followed by aligners when the case is essentially a class 1 case. He mentioned the downsides from this is that it increases duration having these two different distinct stages. So they can be combined in the one-stage protocol. How does this work? Well, initially the TADs are placed, and then the distalizing appliance is placed passively. At this point, there's a scan that takes place to produce the aligners. Once the aligners are fitted, the distalization appliance is then activated. Now, it's great from an efficiency perspective, but there are downsides, and that is having to synchronize the aligner movements with an external appliance of the distalizer. But Benedict Wilmes told us of his research and how he does it. So, the speed of distalization is the key, and Benedict Wilmes in 2012 wrote about the distalization rate using the Benny slider of 0.6 millimeters per month. So he incorporates this into his aligner planning. Bands he found didn't really fit well when it came to aligners, so he switched to using bonded tubes with composite. He also spoke about asymmetric distalization is possible, but he mentioned as a clinical tip to avoid using class 2 elastics for asymmetric correction, as it can create an asymmetry in the mandibular arch. He then went on to speak about mesialization mechanics as well, something that aligners can struggle with. And in 2019, Benedict Wilmes spoke about having bondable tubes on the first permanent molars as well as on the premolars, using a mesial slider, again 2 TADs in the anterior palate, but this time we're going to have closing coils with the appliance. Using a one-phased approach, 0.6 millimeters still seems to be the golden number for the rate of tooth movement. He mentioned one of the advantages of using a palatal retained temporary anchorage device is that class 2 elastics can be used with this process, knowing that we've got the TADs and the slider in place to maintain anterior position of the anterior maxillary teeth. He went on to speak about expansion, and he mentioned using 2 screws in the anterior palate, as this is where we've got thick bone. He uses a BMX expander. Now, he mentioned what this was. It's a prefabricated Hyrax screw, essentially. There's no laboratory involvement because they're prefabricated and come in different set sizes. He spoke about using slow expansion with this Hyrax screw, and he said, well, we have no reason to do rapid expansion anymore, as this was based upon when we had tooth-borne devices, and if this is fundamentally a skeletal appliance, we're not going to have any dental tipping taking place anyway. He spoke about the mini screws being left in situ once the expansion had occurred. He used a Benny plate, something simply to fixate the distance between the 2 TADs and essentially maintain the expansion. He went on to finally describe protraction and using a hybrid Hyrax. 2 TADs in the anterior palate again, this time with expansion from the Hyrax screw, but also using the Alt-Ramek protocol for expansion, which essentially involves expansion for a week followed by constriction for a week over a period of 7 weeks. This is thought to loosen the sutures of the maxilla, so if we were to apply a protraction face mask as well, we'd get greater anterior-posterior movement. The next lecture is entitled Important Pearls for In-House Aligners by Renato Martins. I did enjoy this lecture. I think the advice that Renato gave applies to all types of aligner companies and gets to some of the fundamentals of how we use aligners. So Renato is the founder of eMotion, which is an aligner company based in South America. He recommends the use of a third-party software for aligner design, which is Archforms. Now, Renato described synergistic movements with aligners, and he mentioned that these are the most predictable types. For example, extrusion and retroclination are things which work well when it comes to aligners. And also with fixed appliances, these 2 movements relate to each other, as the biomechanics are complementary when it comes to the distance of forced application from the center of rotation. Now, what Renato described as being challenging movements are the standalone movements. And he mentioned a way to make these more predictable. And that's by divided them into synergistic movements. And he gave a really good example which shows this, and that's the rotation of a lower left one. So if we split the correction of this rotation, i.e. we make half of the rotation corrected by proclining the tooth and correcting the rotation on the mesial side, and then we divide up the second half of the movement, which is by bringing the tooth back in, i.e. retroclining, on the distal aspect of the tooth. And that way we've achieved synergistic movements and corrected the rotation in 2 stages. The second solution to these standalone movements is to change to antagonistic movements. So this is, for example, creating a counter moment. The example he gave was when we're distalizing a canine, we can also cause a distal rotation. And the antagonistic movement will be to create that counter moment, or that forced couple that we have when it comes to fixed appliances. He mentioned this is difficult to achieve with aligners, but his solution was simple, and again it comes back to staging tooth movements. If we distalize the tooth to begin with, we accept it's going to rotate to a degree, and then once it's distalized into the space, we then put the counter moment or counter rotation in to correct things. Renato then went on to describe intrusion movements, and he described the same principle, again, of staging the movements. So if we need to intrude canines and lower incisors, for example, intruding the canines first, and then intruding the lateral incisors subsequently. He described rotations and how they are challenging movements. He always recommends overcorrecting rotations by 30 to 50%. The greater the rotation, the greater the overcorrection that's required. Renato then went on to describe attachment design. Now this was really interesting. He spoke about how the beveled surface should always be the active surface. That was his hallmark principle. But he exemplified it, and he mentioned that some companies will use the 90-degree perpendicular surface as the active side of the attachment. He mentioned that this doesn't work well. He described why. When the active aligner goes onto the surface with the attachment on, it essentially pivots around the active surface. With it being at 90 degrees, there's a greater loss of adaptation for any aspect of the aligner which is cervical to the attachment. He mentioned the solution to this is to have a beveled active surface. Here there's a larger surface for engagement, but also the pivoting that takes place on the active surface is far less due to the graduation of the angle. Therefore, the adaptation on the cervical aspect of the aligner is far better. Essentially, we're getting better expression of our prescription. Now, what Renato did very succinctly is then relate this to fixed appliances. And he mentioned that it's the same as having a nine-tie wire. We tend to focus on the final shape of the arch wire. However, we don't always consider the deformation of the arch wire during the alignment stage itself. And he mentioned it's the same with attachments. With due consideration, we can avoid negative mechanics. He finished off with some really clear clinical pearls. He recommended the use of composite, which was filled for attachments, as ones which aren't filled can abrade. For IPR, he recommended that we go 0.1 millimeter less than what is planned. And he said that's because it's not that precise of a process. Even if we scan cases, once we've scanned them, there's an error. But also once we divide the teeth up in whatever software we use by segmenting them, we're also losing accuracy. So essentially he does 0.1 millimeter less, and in refinement he will do some more. If teeth aren't tracking, his key tip was to check for heavy occlusal contacts. He said this can prevent tooth movement both in an opposing arch but also interproximally, and checking it with a divider. This lecture is entitled Clear Aligner Therapy, Empty Promises or Wishful Thinking by the academic Beom Kim. Key started off by describing if aligners work well. He mentioned that the ClinCheck from Invisalign doesn't represent the final patient's occlusal outcomes. Now, I think that's no new information to any of us, but he mentioned that this was only published by Brushang in 2015, and it took 15 years from the inception of Invisalign for us to really work this out, and he just put into context our level of understanding of aligners, and the rest of his lecture followed this theme. He described the accuracy of tooth movements. In horizontal plane, we are reasonably predictable with aligners, and that was Chara Lampakas in 2018. But for rotational and vertical movements, we are relatively unpredictable. With deep bite reduction, we tend to only achieve 1.6 millimeters of correction, and that was by Khosravi in 2017. And most of that correction is through lower incisor proclination. He described anterior open bites, and as mentioned in the previous lectures, we tend to get a correction by around about 3.27 millimeters, which is really good. This was by Harris in 2020. However, looking at what movements achieve this anterior open bite correction, it tends to be retroclination of the upper incisors by approximately 11 degrees, and only really 1 millimeter of posterior intrusion. Key went on to describe how torque works with aligners. He mentioned that we need to have the greatest force for torque taking place at the cervical aspect of the aligner. And that makes sense. We want to essentially hold on to the tip of the tooth when we're applying torque and put the force on as close to the center of resistance as we can, which is the cervical aspect, to achieve torque. He then looked at the actual strength of the aligner. So where is the force the strongest? And what he showed was that actually it's the incisal tip which is the strongest. We've got close proximity of plastic on plastic, but actually we've got the weakest aspect of the aligner at this cervical aspect. Also, Invisalign and some of the other companies, they're not adapted particularly well at the gingival margin. So on two accounts, we are unlikely to achieve torquing movements. One for the strength of the aligner, and the second is that we can't apply much force to the cervical aspect with the aligner itself. He went on to describe intrusive movements, and he described proclination of teeth being the main component of this. And as a thinking orthodontist that Key clearly is, he looked at, well, how do we achieve a true intrusive movement? And what he found was that by placing a lingual attachment, we don't quite create enough counter moment to stop this proclination. Actually, what we need to do is purposefully retrocline the incisor whilst we're doing an intrusive movement, essentially creating that counter moment. He then showed a really interesting study looking at attachment design. So this was where they took a rotated premolar, put different attachment designs and positions of attachments onto that tooth and put that typodont into a water bath. And it was really interesting to see what they showed. This was by Mumtaz in 2017. And it showed that there was 60% prediction with no attachments. When there was an attachment, it was increased to 70%. But actually, as they increased the attachments on the adjacent teeth, whether it was buccal and lingual, the accuracy reduced. And how counterintuitive is that? But it actually went down to 27%. And what Key said in a very frank sense and very informed was that we don't truly know how attachments work with the interaction with the aligner. He spoke about the accuracy of aligners to outcomes, and they range from 77% for tipping movements by Wheeler 2017 to 50% of overall tooth movements, which is in the paper from this year by Howley in 2020. He described how extraction of first premolar research has given more insight as to how aligners are. So he looked at a finite model analysis, and it showed that we get uncontrolled tipping of the upper incisors. That was by Jiang in 2020. He spoke about how molar anchorage loss in first premolar extraction cases is greater than is usually planned on ClinChecks, of 2 to 3 millimeters. We tend to also get mesial tipping of the upper first molars of 5 degrees. We get reduced retraction of the upper incisors, only usually around 2 millimeters, and also there's retroclination of the upper incisors greater than what we'd expect of 5 degrees. This was Dye's paper in 2019. So Key's done a study where he observed what changes take place to adjacent teeth when we are active with anterior teeth. And this was again really interesting. Key showed that actually we don't get equal and opposite forces occurring on the adjacent teeth. What we actually get is really unpredictable movements on adjacent teeth. He said that they are biomechanics which are complex, and the occlusal forces add a dimension to aligner use which we still haven't quite grasped. Key spoke about developments in aligners, and it was really interesting. He's working in conjunction with a Southeast Asian company, and they're looking at printing directly to aligners, but also means he's customizing the design of the aligner, changing the thickness where required, and making things more efficient. And I look forward to seeing Key's research in that respect. That's the end of day 2. I've taken a lot away from today's lectures. The key components are to look at where the anchorage loss is going to take place and counter it by using elastics or TADs, but also to be realistic with the movements with aligners and start to appreciate the limitations with the strength of the application of force. Hope you've enjoyed this episode. Please do subscribe and look forward to the next episode.